Okay, so this next recording we're going to talk about specifically type 1 mediated hypersensitivity reactions. And so these are the allergic reactions that we're very well aware of to environmental antigens. So the type 1 responses are going to be driven by a Th2 cell, and this is going to generate the IgE that is known to initiate the allergic response. Mast cells are going to be the mediators of the allergic response. If this was a parasitic infection, it would be the eosinophils as well. Now, eosinophils are known to be participating in chronic asthma and some chronic lung diseases. But in a type 1 hypersensitivity allergic response, mast cells are the mediator of these. And it's because mast cells are in your tissues, whereas eosinophils are not. They have to be recruited. So they do not get recruited in a very quick type 1 hypersensitivity reaction, but they will be recruited if there is a parasite or a chronic type of disease. So some of the diseases associated with our type 1 are listed here: rhinitis, asthma, anaphylaxis, and dermatitis. Okay, so we're just going to talk about some definitions in general. So atopic is a term that was used as hypersensitivities tended to run in families, and so it was a term that was used to describe predisposition to allergy. And then the term allergy was simply the altered reaction to exogenous antigens. And nowadays, they're both sort of used interchangeably. They're known to be both mediated by IgE. And so if you talk about atopic, you typically are referring to an allergic response. There is also another term that's used called the allergic march. And this is the development of allergies at different ages in your lifetime. So maybe you were allergic to grass when you were a kid, and now you're allergic to wheat, or you're allergic to dust mites as you get older. So this is the allergic march, that your allergies and the triggers for your allergic responses change over time and at different ages. The allergen is the actual antigen, and this antigen is going to cause the allergic reaction. And this can be inhaled, such as spores, pollen, dust mite. And dust mite is really the feces, which is an enzyme that causes trouble. Or it can be injected, such as venom. You could also say it could be ingested, such as foods. And then with respect to type 1 hypersensitivities, there are some classic diseases that develop because of them. Anaphylaxis, of course, is the most important to get really advanced treatment for, or very fast treatment for. Anaphylaxis is an acute allergic reaction. And this is to an antibody which the body has a hyper response to. And it's a systemic response. Angioedema is a painless swelling under the skin. And it's caused by an allergen. Urticaria is going to be a rash on the skin, and it's itchy, and it's usually associated with food allergies. There's also rhinitis, which is inflammation of the mucous membrane of the nose, and it can be caused by a virus such as a cold or an allergy such as hay fever. And then, of course, there's asthma, which is a respiratory condition with spasms of the bronchi, which causes difficulty breathing. And then there's also dermatitis, which we have skin that's red and swollen, and it may blister. And then eczema, which are patches of skin that become rough with blisters. And this can be itchy and bleeding and can become inflamed. Okay, so the diseases can be systemic. It can be related to the respiratory tract and your airways. It can be in the skin. And if it's systemic, you can have anaphylaxis, which is going to lead to low blood pressure, angioedema, and airway obstruction, which can be fatal. Typically, this is going to be caused by our food allergens, such as our shellfish and our peanuts, tree nuts. It can also be triggered by antibiotics reactions to our penicillins and classes of different antibiotics. Those that are going to be part of the airways are going to lead to our typical hay fever, or we can have asthma, which is going to be obstruction that's reversible of the bronchi. Rhinitis is what we typically think of an allergic response, sneezing, watery eyes, etc. Urticaria is going to be itchy edema, and it's going to be very short-lived in the skin. This is going to be usually what you see when you do a skin prick test if someone's positive for an allergic reaction to an allergen. Angioedema is also going to be short-lived. It's going to be non-itchy of the subcutaneous tissues. And this is usually caused by food allergies. Atopic eczema is going to be chronic and itchy with inflammation, sometimes bleeding, and some of the eczemas can be caused by food allergies. Now, just a note here, the above, all of these different clinical syndromes can also be caused by non-allergic mechanisms. Infections, for example, can trigger airway obstructions, sneezing, etc. All right, so peanut allergies are very important. Peanut allergies are going to be typically caused by a person who's sensitive to the peanut proteins. So you have sensitization. which in essence means a primary response. And you can have it to a peanut protein ARAH2, or a peanut protein ARAH8. And ARAH2 is a stable protein. So this means that if you cook it, if you eat it, stomach acid won't inactivate it. If you cook it, won't inactivate it. And so this is the cause of the severe systemic reactions. You can measure tryptase levels in the blood, which indicates mast cell degranulation. And this is where you're going to have a swollen face. You're going to have itchiness, drowsiness. This is angioedema. Be drowsy, low blood pressure. And this can go to shock. And then this little guy down here, this one is unstable. And so this is not going to cause all those symptoms. It gets destroyed by heating or your stomach acid. Latex is another common allergy, as well as penicillin is another type of allergy that comes up. So for latex, the cause is going to be rubber, banana, avocado, kiwi. They're all related, and often there is cross-reactivity with all of these different types of antigens. And then penicillin. This is going to be against the beta-lactam ring, which is part of the structure of this class of antibiotics. And so this ring is shared with penicillin, amoxicillin, coccycillin, cephalosporins, and all of these can cause anaphylaxis. So this is just a skin prick test example. This came from your book. So for example, in your skin, you're going to have a mast cell with IgE. In the skin prick test, you're going to expose these skin mast cells to different antigens, potential allergens. If there is something that activates the mast cell, it will release its mediators. And then the mediators are going to cause vasodilation, opening between the endothelial cells to allow for diapedesis. And you're going to get a leakiness, so you get a flare, arrhythmia, and then dermal swelling, which is known as a wheal. So this is called the wheal and flare. Okay, and so that's kind of what happens when you have an allergic reaction. You have the initial very quick wheal and flare reaction. um, which is just characteristic of a type 1 allergy. Okay, so for sensitization, we have, of course, the allergic response is a memory response. Do I still have that? Yeah. So sensitization is the same thing as that primary exposure, so it leads to memory. So the actual allergic response is a memory response. And keep in mind that a mast cell is tissue resident. And it will hang out in the tissues. And it will have on its surface its Fc epsilon receptor. And then attached to this Fc receptor is going to be various IgEs. So I'll have a red one and a pink one. And we'll put in a blue, green, purple, and a brown one. So of course all of these IgEs are specific for some particular allergen. And then you have a antigen that will bind to the IgE, and then it will activate the mast cell. Now, depending on the type of antigen, there's one that's local, so you'll get a local response. And then number 2 is systemic. And this is where you get a systemic response. Now, of course, your Th2 cells here are what are going to initially cause your B cells to become IgE producing. And so this is definitely an antigen or allergen that's being that's stimulated both B and T cells in a Th2 environment, a non-Th1 but a Th2 environment. Now, after you have this sensitization, you can now degranulate in your mast cells. So you have IgE cross-linking of their Fc receptors, Fc regions, I should say. And IgE, I should say, antigen bound. And so this is going to lead to allergy. Now, your mast cells are going to have different types of granules, and they're going to have early phase granules that are going to release their mediators within seconds. And then you're going to have late phase components that get released later during the allergic response. Now, a few notes. Complement can activate mast cells. But remember, if complement is activated, it's specific in a tissue, so you're not going to get that systemic activation, so it's not going to lead to that anaphylactic type of reaction. It's going to be a very, it's going to be in the tissue in which it's being activated. And also, temperature changes can activate complement. Now, with respect to allergy predisposition, About 40% in the developed world have some sort of allergy. And it tends to run in families because of twin studies, so there is a genetic basis. Okay, so it's thought to be about 80% of risk is genetic. And it's inherited, not the type of allergy. It's only the risk. So one twin might have hay fever and the other twin might have asthma, for example. And there is a higher prevalence of allergy, of course, in developed countries. There's been a lot of proposals about why that is, such as the hygiene hypothesis and things like that. And so it is important, though, that it's noted that the more clean of an environment we tend to create for ourselves, the increase in the allergy seems to be. And it would make sense because we all know that in order to get a Th1 response to an antigen, you have to have inflammation. So if you don't have those toll-like receptor triggers in the environment because it's too clean, and you get an environmental antigen, it's going to get activated. Your B and T cells are going to get activated in a non-Th1 environment, which will drive an allergic response or an IgE response. But there are other reasons why we want to have a clean environment. Pathogens can kill us, so it's weighing the risks of both of those types of scenarios. Okay, so we do have a particular protein, and this particular protein has different polymorphism in people, and some of those lead to allergies. So you have filagrin, which is shown here. And this is involved in just moistening. It's important for, it's made by your keratinocytes of your skin. It's important for cytoskeleton, important for tight junctions, maintains epithelial cell barrier. But this particular protein is going to be broken down. So I'll write what is important for cytoskeleton, and it's going to be important for tight junctions, and epithelial cell barriers. But just like any protein, it's going to be broken down into peptides. And these peptides have natural moistening factors. And so it keeps the skin pH low. And so this is protective. Now the polymorphisms are going to affect epithelial cell barrier. So the function can be affected of this protein. And it can decrease the epithelial barrier. And this is seen in about 50% of all eczema, severe eczema patients. All right, so let's go through all of our responses, or a few of our responses. We have what's called an early phase response, immediate response, and these are going to be components of mast cells, granules. And so these are preformed. You're going to have, of course, the Fc epsilon R1, which binds to the IgE. And then the IgE, of course, will bind to the antigen and crosslink. The mast cell will also be able to produce prostaglandins and leukotrienes. This is going to help with vasodilation, increases permeability. You're also going to have leukotrienes. You're going to have fluid movement, and it's going to move from vasculature, because now you're getting more leaky, into extravascular space. And this is going to decrease vascular tone. And you're going to have, if you have widespread mast activation, this can decrease the blood pressure and you can lead to anaphylaxis. So if we have systemic. And then you have early or immediate is also called often a wheel and flare reaction. So we're going to get redness and swelling. As serum is going to move into tissues as well as blood. Now, diagnosis is going to be where you're going to have the ability to see symptoms, of course. So you can have airway obstruction, you can have wheezing, and this can be within seconds. And you can measure an increase of tryptase in the blood. There are kits to do this, and so it is an indicator of mast cell degranulation. Now, a late phase response is going to be when it's hours. You're going to get recruitment of your leukocytes. And this is going to go into the bronchi. And this is caused by cytokines. You're also going to get Th2 cytokines made, which will help to just keep that Th2 type of environment. Now you can have your leukotrienes, and corticosteroids are going to be given as a treatment. They're going to inhibit mast cell mediator synthesis. And then you also have immediate effects if you give steroids, epinephrine. You can have beta 2 androgenic antagonists, and these are all going to also affect the release of those inhibitors. And the goal is to especially block those early phase mediators with these treatment options. So again, we have those beta 2. And we also these are going to prevent smooth muscle contraction. We have epinephrine, which is going to be life-saving, especially to those who have systemic allergic responses. Those EpiPens. Anaphylaxis is going to be a decrease of blood pressure. And so you're going to want to reverse that by treating with epinephrine. Epinephrine is going to stimulate the alpha-beta receptors to decrease vascular permeability and increase the blood pressure. Corticosteroids are going to prevent the immediate hypersensitivity moving into the late and chronic phases. Okay. Oops, sorry. So this is just a way, a desensitization technique that's being used now for many different types of allergens. And so basically, if you have, in this case, this is showing a bee. If you have a bee sting, then the bee sting is going to induce a Th2 response, an IgE. If you take that same bee venom and you give a sub-Q injection of it, you're going to favor making those inducible Tregs, so an iTreg. And the idea is if you can induce Tregs to counter the Th2 responses to the bee venom, then you can potentially dampen the allergic response. One problem with this, though, is that you always have those lovely plasma cells that are still cranking out IgE, regardless of the Treg influence. And the mast cell really isn't going to be influenced by Tregs either. Okay, so that is the end of our mast cell. And thank you.